Hello, everyone. Welcome to the 51st Union Conference. My name is Peter Whitty. I work for an organization called Water Youth Development Projects, an organization that is involved in advocacy. And I will be chairing this session. And with me, I have Kati. Kati, would you please introduce yourself?
Hello, everyone. My name is Kathy Feekard. I'm a senior TB consultant at Kane Severe Tuberculosis Foundation. Welcome, everyone, to this session. Over to you, Peter. Hello, everyone.
Hello, thank you very much, Kachi. Now, this session, we are going to talk about different approaches to improve treatment. And with us, we have 4 speakers who are going to be with us in this session. We have Rarajam Poti, which is working with the Kalamaka Health Trust promotion. Then we have Pius Omarengo, who is a district TB and leprosy supervisor at the Kapelolong Health Center. Then we have Veshar Rai, who is who works for the government at Madhya Pradesh in India. And last, we have Eunice Muturi, who is working with KNCV-TB Foundation in Tanzania. And so we are going to have the speakers in that order, and we are be happy to hear from Rajaram. Please, thank you and welcome.
Good afternoon. Greetings from Bangalore, India. I am happy and privileged to present our paper on community health workers augment the cascade of TB detection to care in urban slums of 2 metro cities in India. A study that aims to assess the effect of community engagement on the TB care cascade under the Tuberculosis Health Action and Learning Initiative project. The TALI project funded by USAID is a person-centered initiative supporting vulnerable urban population to gain access to TB services. TALI recruited, trained and retained 112 community health workers to support individuals with TB symptoms or disease within urban slums in 2 cities, namely Hyderabad and Bengaluru. Community coordinators supervised and supported the CHWs in the field. The CHWs work in close collaboration with the TB health visitors, the frontline workers within government-sponsored National TB Elimination Program. The population coverage in the urban slums was about 3 million, 1 community health worker for about 25,000 to 30,000 urban slum population. We examined the achievements from this approach by comparing 6 monthly patient cohorts within the TB cascade of referral, diagnosis, treatment, and outcome. For patients who initiated treatment and referred between September 2016 and December 2018, only the first cohort was of less than 6 months duration. The community engagement through community health workers was based on the person-centered continuum of care approach. This engagement was initiated by adopting a process of slum mapping and focus area mapping. During this process, the CHW shared information on TB with key opinion leaders, community groups, and individuals. Individuals who had symptoms were referred and accompanied for TB testing. CHWs documented referrals in a tool known as Patient Referral and Diagnosis Card, PRAD. Once the individual was identified to have TB disease, they were counseled and supported for treatment initiation. CHWs monitored treatment adherence, provided information and linkages for nutrition support and direct benefit transfer of rupees 500 per month under the Government of India program. They identified a family level supporter or supporters. Contacts were also screened for TB symptoms and referred accordingly for diagnosis. The CHW visited the TB patient and family at least once a week during the intensive phase and once a fortnight during the continuation phase of treatment until treatment outcome was declared. Follow-up visits after that were once a quarter. All actions performed and progress of the patient during the follow-up was recorded in the prevention care and support card or the PCS card. Thus, we are able to analyze the entire spectrum of TB care cascade using these two tools, the PRAD and the PCS. We categorize the patients according to 6 monthly referral cohorts for a period starting from September 2016 to December 2018. We examined the entire spectrum of TB care cascade. We applied multivariate logistic regression models in order to determine the likelihood of successful treatment across various cohorts after controlling for potential risk factors that were associated with treatment outcomes. TALI's overall contribution to TB notification in these two cities with a total population of about 20 million was found to have increased from less than 1% in 2016 to 7.2% 2 years later, a 10-fold increase. CHWs referred 29,000 people living in the urban slum areas, approximately 1% of the total slum population of both the cities. About 75% underwent TB tests, 16%, close to 3,500 were diagnosed as TB. 99% were initiated on TB treatment and 71%, nearly 2,500 consented for regular follow-up. 90% of those who were followed up had a successful treatment outcome, defined as completed treatment or declared cured. Over the period, one can visualize that there was an improvement in the number of referrals. The percentage of referred persons undergoing diagnostic tests improved over the time period. And the number of persons diagnosed with TB also improved and stabilized at around 1,000 for every referral cohorts of 6 months. Almost all patients diagnosed with TB were initiated on treatment, which is more than 99%. However, one challenge encountered was that not all persons identified as TB patients through the CHW referral consented for follow-up visits. Successful treatment outcomes among those followed up were consistently high. Finally, we examined the likelihood of successful treatment outcomes among various referral cohorts after controlling for the various factors using the stepwise backward deletion multivariate logistic regression. We identified a significant improvement only in the last referral cohort in comparison to the first referral cohort. The key message from the results that community engagement through CHW is feasible and does improve the care cascade of TB detection, treatment, initiation, and successful outcomes. The CHW engagement with the slum population augmented the TB detection as well as treatment outcomes over the time period. Case detection increased fairly rapidly, but it takes time before treatment outcomes can be improved. It would be useful to analyze the cost-benefit of the model in terms of TB patient detection and successful treatment outcome. We express our sincere thanks to the organizing committee for giving us an opportunity to present our work. We thank our donor USAID and the government and our civil society partners for their dedicated support. Finally, we would like to acknowledge the significant contribution of community health workers who have made it to the TB detection and treatment outcomes. We also salute the efforts of the individual patient and their supportive family members, without whose dedication the desire to be cured, these results would not have been achieved. Thank you.
Thank you. My name is Pius Ongareno in this 51st Union World Conference on Lung Health. Next. Next. I will be presenting the abstract titled Improving Isoniazid Preventive Therapy, IPT Coverage Among Children Aged 0 to 14 years Living with HIV through Designating Special Clinic Days, a case of Kaplebyon Health Center 4. Next slide. Next slide. Next slide. Introduction. TB is the leading cause of morbidity and mortality among people living with HIV, and HIV remains the greatest risk factor for TB. TB-HIV co-infection is associated with faster disease progression, severe disease forms, and higher mortality as compared to adults. Isoniazid preventive therapy is one of the 4 interventions Uganda adopted to prevent TB among PLHIV. Despite of its prevent risk reduction of over 60%, the uptake is still low. Next. In February 2019, at Kaplebyon Health Center 4, the IPT coverage among 0 to 14 years was only at 9% against the 80% expected. This was attributed to mixing of clients during general HIV clinic days, knowledge gap among clients, parents, and guardians regarding IPT. This limited opportunities for tailored health education messages, screening, and enrollment on IPT. Next. We did intervene in a stepwise method. In step 1, we set up a multidisciplinary team comprising of all the cadres, clinicians, medical officers, nurses, midwives, counselors, and the peers. We did a root cause analysis of the problem using a fishbone method. Clients' HIV cards were retrieved and reviewed. In step 2, special clinic days were identified and displayed in clinical rooms and the main notice board. Appointment synchronization was observed. We had parents and caretakers in this case who also got care in the same clinic, and it was wise to have the child and the parent get care on the same day to increase on the sustainability of the approach. Quality improvement concept was applied and the journal opened to track progress. In step 3, clients, parents, guardians were carefully engaged through targeted information giving in the breakaway sessions. Data collection and review was done weekly, and quality improvement the journal was updated on monthly basis. Next. Now, next. Now, here is the fishbone analysis method that we use for identifying the problems. At the head of the fish, we realize there is a big problem which we are aiming to solve: low IPT coverage. And we had 4 areas to look at: the products, policies, procedures, and the people. We had issues in the procedures whereby we used to conduct mixed HIV clinics, which limited opportunities to give tailored health education, but also limited screening and enrollment on IPT. People-related problem was knowledge gap among the parents, caretakers, and also the clients themselves regarding IPT, which caused missing of their appointments and reduced social and family support because of not understanding the importance of the IPT. Next slide. Here we look at the few clinic picture days. The first picture shows the ongoing screening on IPT. The second one is the breakaway session for parents and caretakers. This is where they shared challenges and their successes on how they are managing giving their children ARVs together with the IPT, but also a golden moment when we could impart them with the knowledge and importance of IPT to them, to the children, and to the community. We had in picture 3 a breakaway session for the children, where they could also learn from each other and strengthen each other to carry on with the IPT together with the ARVs. We had to keep these children busy and interested in the clinic through games, as you can see in picture 4. Next slide. Here are the results. Is a graph showing cumulative coverage of IPT among 0 to 14 years HIV positive in care at Kaprebiong Health Center 4. Now, the blue bars show the total active of 0 to 14 in care. The orange show the cumulative number enrolled in care. The gray curve, the gray line shows the percentage achievement, and the target line in yellow. We realized in Feb we were low at 9% coverage of IPT, but over time, when we intervened in around April with special clinic approach, the June, July, August, by September, we had surpassed the target of 80% to 85%. Next slide. Conclusively, designating special clinic days allows the health workers to offer comprehensive care package, including IPT. Programs should prioritize development and implementation of guidelines on formulating and sustaining special clinics, which offers opportunities to deal with unique challenges and help achieve optimal treatment outcomes among HIV clients. Next. We acknowledge all esteemed staffs of Kaprebiong Health Center 4, District Health Office of Kaprebiong, Regional Quality Improvement Soroti, Uganda, Ministry of Health, National TB and Leprosy Program, Uganda, PEPFAR, CDC for their support to the Ministry of Health, Uganda, the lead IP, the AIDS Support Organization, TASO, not forgetting the AIDS Healthcare Foundation, Uganda Cares. Thank you.
Namaskar, good morning. I am Dr. Varsha Rai, the State TB Officer in Government of Madhya Pradesh. Today I am presenting using market-based e-pharmacies for delivering free TB drugs to patients treated in private sector in Madhya Pradesh. Background. In India, more than 50% of the TB patients are treated in the private sector. The private providers uses different kind of the diagnosis and treatment quality. There is no track record of patient and follow-up by the private sector. Most of the private doctors, they don't have the record for the treatment completion by the patient. High out-of-pocket expenditure by patient is one of the major cause for the non-adherence for the treatment completion. Despite Government of India's commitment and provision for free diagnostic and drug delivery, there is no effective mechanism, especially in my state. Now the big question is why e-pharmacy is needed. If I talk from MP prospectus, then there are the major key determining factors which are associated with e-pharmacy. E-pharmacy market is already aggregated key private players like doctors, hospitals, clinics, lab, pharmacies. E-pharmacy companies have resources to provide last mile delivery. The e-pharmacy technology platform providing end-to-end tracking mechanism. Now the function and the process flow of the e-pharmacy, how a notified TB patient can avail this services. You can see this flow chart. In first step, the presumptive TB patient consult their doctor for diagnosis. After that, the PSI field staff or the clinic staff, support staff, they registered the patient and upload prescription and link patient for DBT, assured drug supplies and drug store. In this step, they send the patient to government lab for CBNA testing or the sputum examination. After that, they validate the prescription. Then medicine collected by e-pharmacy logistic. FDC drug secured from NTP drug store. E-pharmacy packages drug in their standard boxes. They collect the drugs from the state drug store or the district drug store. Then e-pharmacy validate prescription and other details. They create order in their system and alert logistic. After that, they notify the patient in Nikshay. Prescription is uploaded WhatsApp by patient in e-pharmacy. After that, the staff of PSI, they collect the medicine and deliver the medicine to the patient's doorstep. Midlife send SMS alert to patients and deliver the consignment to patient home. Midlife through call center will put reminders 10 days or 5 days before next refill to the patient's complete full treatment cycle. After that, patients follow up and records medicine next month. In this model, free CBNA diagnostic for patient created in private sector by using the market-based platform of e-pharmacy. E-pharmacy uses the technology platform for receiving order for sputum collection from the doorstep of patients, transport to CBNAT lab and online report. E-pharmacy receives order for free TB drugs against the valid prescription and delivers NTP drugs to the patient's doorstep. The technology platform provides reminders to the patient for treatment adherence and refill of the drugs. In this graph, you can see the tremendous increase in the drug packages delivered to patients' doorstep, and this is increasing rapidly. You can see in January 2020, the number of patients was 25. After that, in February 2020, 88, then 163. After that, 172, 168. Then in June 2020, 250 patients. Drug packages delivered to patient doorstep in July 2020 is 836 patients. The major achievements of e-pharmacy: first of its kind contract signed with Midlife International Private Limited with our partners. The Midlife International Private Limited, one of the leading online pharmacy in India, following lengthy negotiation. Intervention rolled out in Jabalpur in December 2019 and Indore and Bhopal in February 2020. In 3 districts, we are using e-pharmacy. 564 presumptive TB patients provided with sputum sample collection and transportation services and tested at CBNAT lab. Around 976 TB patients started receiving FDC drugs from NTEP with more than 2500 drug packages delivered to patients' doorstep. Extended pallet to patient in public facility to ensure treatment continuation during COVID pandemic. Thanks to our development partners USAID India, PSI and ABT Associates. Thank you.
Hello and welcome to my presentation. My name is Eunice Muturi, working with KNCB Tuberculosis Foundation as the Digital Health Technical Officer in a project called Ascent. I'm very pleased to be presenting to you today the potential of mHealth to enhance and improve TB awareness and case detection in Tanzania. I have no conflict. Tanzania is still among the top 30 countries with high TB burden. Despite the high treatment success rate, case detection still remains low. In 2017, the estimated annual incidence was 154,000. But in the same year, we reported 44%. 56% were unidentified. We saw the same trend in 2018, where the annual incidence was 146,000. We reported 53 and 47% were missing. The NTLP had to come up with an intervention which was going to be able to reach people, help people get this TB knowledge, which is the main challenge that we have in Tanzania, lack of TB knowledge in the affected communities. So they came up with an intervention called Mobile Health for TB Control. So mobile health technology is an opportunity to reach high numbers of people across the country in both urban and rural settings. let's say 78% at least have one mobile phone in their families. This application was going to be built on already existing government infrastructure for sustainability. So the NTLP collaborated with Challenge TB project, which was a USAID funded program, and also engaged an organization called Cardinal Tanzania, who were already maintaining the existing government infrastructure and will help us develop this mHealth application, which was going to do self-screening and share TB knowledge to the community. The process of developing this application was quite a long one. It took almost a whole year. We had various workshops and meetings with various stakeholders and partners who were really eager for us to roll out this application. We had workshops for developing the mHealth concept note and a work plan. We had a meeting for technical requirements. We had another meeting for developing content, the message which was going to use in the application, and also pre-tested the messages and also costed the messages. So the main objective of this application, as seen in this designing activity, in this slide, designing a TB mHealth app, it was to raise TB awareness in the general public. It was to promote self-screening and create demand for testing, and make sure that it bridges the gap from the community self-screening for TB to the health facility for diagnosis. So the application was launched in September 2018 by then Deputy Minister of Health. And to create demand for use of this application, we developed TV spot, which we aired on televisions, radio spot, we aired on local radios, and also printed information materials, that's posters and pamphlets, which were shared in the community, which had the instructions on how to do TB self-screening. So this is how the application works. You just dial this code here, and then it'll take you to a menu where you will select tuberculosis, and then it will take you to another menu where you will select either you choose TB self-screening or TB information. So for those who want to do TB self-screening, the clients will be asked a series of questions of personal particulars from their age, region, district where they're living in, their gender, and then the 5 TB screening questions. And at the end, the platform will classify the individual, the client, if they are self-reported presumptive or they are non-presumptive. For the non-presumptive, they'll continue receiving TB educative messages, and the presumptive, they'll get a message from them to go to the health facility for the diagnosis, and also another message to tell them if they were unable to go to the health facility, a healthcare worker will reach out to them to direct them to the nearest health. So this is the most current self-screening dashboard snapshot. The people who have access to this dashboard currently are the NTLP and the Cardinal Tanzania, since the Challenge TB project phased out last year. So this snapshot was taken in August 27th, 2020. So this application is still on use. Since the launch September 2018 to April 2019, 898 individuals had completed self-screening. Among them, 1,606,758 were self-reported presumptive. These were data from all of Tanzania since the application was rolled out the whole of Tanzania. The NTLP had to make sure that these self-reported presumptive were able to reach the health facility for further diagnosis. So they came up with the strategy of giving access to all district coordinators, TB coordinators, but the constraint came on finance now that we had to only give access to Challenge TB regions, which were only 6 among all other regions in Tanzania. So the 6 regions, all the district coordinators were given access to the dashboard. They downloaded the numbers of individuals who screened from their districts and were able to call them up. And the feedbacks they received, some of them were testing the functionality of the applications due to mere curiosity, and others were just teaching others on how to do self-screening. And this led to the increased numbers in the self-reported presumptive. And truly, there were others who had the symptoms of tuberculosis. So these are the people who the healthcare workers reached out to them. People who have followed up by the healthcare workers, or the clients or the self-reported presumptive were followed up by healthcare workers, by 2,058. Among them, 625 confirmed to have reached the health facilities. This is data from January to March 2019. So among the 625, 201 confirmed to have tuberculosis, and they were able to share their TB register numbers, which we could trace to the unit registers. and also to the electronic TB register for confirmatory. Before I go to the lessons learned, I want to just show this slide here that this application reached more adult men than women. It's known that more men are prone to have tuberculosis. We presume that if this application helped them have this early health-seeking behavior with these prompting messages from the application. So the lessons learned here is that this application actually works, but however, it's not sufficient enough for it to be to bring patients to the clinic. That there's a need to add more modules to improve the application, modules for electronic referral and contact tracing. Also, it's appropriate to consider human and financial resources beyond the project life cycle for sustainability of the intervention. Also, this intervention goes hand in hand with the mass media campaigns. When there's no mass media campaigns, people tend to forget to use this application for screening themselves. In conclusion, we could like to recommend that this application be linked to the diagnosis and also to treatment initiation so that we can fully see the potential of this application, or see how many patients is contributing to notification. This application, the mHealth for the self-screening application, is user-friendly and it's acceptable. And actually it gives the clients power to take charge of their health. And also it offers them privacy. It can be the light, the little light at the end of a dark tunnel, which can guide us find these missed people with TB. Let us marry this digital health and human together, and let us understand that these applications or tools do not belong in a vacuum, they belong with the humans. I would like to acknowledge all the people who supported drafting this abstract I've presented today. I acknowledge all the authors and all the organizations who contributed in one way or the other for this intervention to be a success. Thank you.
Hi, everyone. I'm Jennifer Zelnick. I'm presenting today on behalf of the Praxis study, and I'm going to be talking about identifying subpopulations who are at high risk for severe adherence challenges in the treatment of multi and extensively drug-resistant tuberculosis and HIV. I have no conflicts to disclose. So here is the Praxis study team, and I'll give you a moment to look at everybody's name while I acknowledge our staff, and of course, our participants and their families, and our funder, the National Institutes of Health. Okay, so in general, this is going to be my overview. I'm talking about, we're talking about how in generalized epidemics of drug-resistant TB, it's important to identify those subpopulations who may be at high risk for adherence challenges, for most importantly, for treatment outcomes for individuals, families, and communities, but also to prevent amplification of resistance while on treatment. So our hypothesis was that we could use an electronic dose monitoring device to empirically identify these patients in real time, and then a mixed methods approach to characterizing their treatment challenges. So in regards to background, we conducted our study in South Africa, in KwaZulu-Natal, in the context of the introduction of bedaquiline for the treatment of drug-resistant TB, and also the context where so many drug-resistant TB patients are HIV co-infected. Adherence to each regimen when they're an issue, patient is taking them together, is critical, but it remains generally pretty understudied. And as I said, we use this approach with the electronic dose monitoring device and the mixed methods for characterization. So this was a prospective cohort study of adult patients. Our participants received 2 electronic dose monitoring devices, one for bedaquiline and one for ART. And then we calculated their cumulative adherence over the 6-month period as recorded compared to expected device openings. And patients with less than 85% adherence to each medication were considered dual adherence challenged. And then we use focus groups as well as other types of data to characterize their adherence challenges. These are our results in terms of enrollment. 422 TB patients were screened for eligibility, and ultimately 198 were available and included for analysis here. So these are the cumulative adherence pattern results, and the group that we're focusing on today is the group in the blue box. These are those with less than 85% adherence to the antiretroviral as well as bedaquiline. That's 16% of the population, 32 patients. I also want to draw your attention to the yellow box in the upper right-hand corner. This is the group that had both over 85% adherence to bedaquiline and ART with no intervention at all, a very promising result in terms of this population who struggled with difficult treatment. Okay, so here's our table one. So among the enrolled participants, about 57% were female. The median age was about 35. 10% were receiving a disability grant, and the median reported household income was around $145. If you have a chance to look through this, you'll see that in most of the areas, the dual adherence challenge group and the non-dual adherence challenge group are pretty similar on baseline. In terms of predictors of adherence based on this data, in univariate analysis, fewer of the dual adherence patients had an undetectable HIV viral load at baseline. This is referring to the previous table, but that was 47% versus 65% of those who were dually adherent. However, in multivariate analysis, only receiving a disability grant was a predictor of being in a dual adherence challenged grouping on the WISE pill. So we also collected this information about the experiences that patients went through as they were taking treatment for 6 months. And this data was collected from routine clinic visits, as well as the troubleshooting phone calls that we made to check in on use of the electronic dose monitoring device. And you can see that there were a lot of challenges that people had, things like emotional challenges, mental and behavioral, lack of care engagement, self-isolation, stigma, many different severe challenges. So this is a box that represents our focus group results. We did 4 focus groups with dual adherent versus non-dual adherent patients. And one of the things we found is that patients overall face many of the same barriers and many of the same issues with difficult treatment and juggling time and everything, but their attitudes toward these things were quite different. So patients in the dual adherent group described embracing their treatment, never hesitating or missing any. The dual adherence challenge patients tended to express doubts. They had comparatively less trust about patients, saying things like they were confused about the role of medication and your body is controlled by medication. The dual adherence challenge patients also described engaging in social activities that kept them away from home, or having more problematic social support systems, whereas the dual adherent patients described their motivations and their successes in making efforts to prioritize treatment and the support of their families. Sorry. Technical difficulty. And to drive the point home, this is a Kaplan-Meier curve that shows you the difference in mortality, sadly, between the 2 groups based on their adherence pattern. So in conclusion, we were able to identify a subpopulation who really struggled with adherence challenges to bedaquiline and ART. We think the results of the importance of our results is not so much to say that people with adherence challenges have poor outcomes, but it's really to say, on the one hand, it's difficult to use baseline data, at least as we collected it, to predict these adherence patterns. And at the same time, we were able to document a range of specific challenges that people experienced. And so we think that this data will be quite useful in creating targeted interventions for patients within a general population who struggle with severe adherence challenges to their medication and engagement in care. Thank you.
Go. Thank you very much, everyone, for some really interesting presentations and some new ideas. And lessons learned for all of us, I think, especially in this difficult time with the COVID pandemic on top of everything else. We're now starting a question and answer session. So if you haven't posted any questions yet, but you want to ask us something, please type them into the question box. Do not use the chat. You can use the chat for any positive comments or negative comments, whichever, but questions, please put them in the question box. It makes it easier for us to address them to the right people. Please also address them to the person that you want to ask them from, because it's not always obvious from the questions who to address them to. We've already got a few questions. If you see the questions and you are really interested in them as well, you can also upvote them. The more likes a question has, the sooner it will be answered. Questions that we will not get to today, we will try to get back to you during the rest of the conference. So there is one first question for Eunice. There was actually a number of questions for Eunice, and we have already answered them in writing, but just could you tell us a little bit more, Eunice, please, on how you dealt with having the platform in more than just the English language, using local dialects or local languages. Can you speak a bit more to that, please?
Yeah. First, we had to come up with experts who are able to develop the messages and translate them from English to local language, which is Kiswahili, so that the larger group of Tanzania could understand how the application works. So it took quite a long time. Even the messages which we developed were pre-tested by the end users, who are the clients and the people in the community, and they accepted the messages. So that's the context of how we developed these messages, and that they were tested and they were approved by the government and by the end users. So yeah, it's in the context here.
Thank you very much. The next question that we have is also for you, Eunice, but we've got you online here. Thank you for your presentation. I saw that nearly 230,000 people did self-screen. Can you say something about the coverage?
Actually, the application was rolled out in the whole of Tanzania, and it has Tanzania has about 59 million individuals. The application was implemented for only 7 months. So within those 7 months, that's when we were able to get individuals screening themselves. Those 266 people were able to complete the self-screening. So it wasn't a big number, but I believe if we could have continued implementing the intervention and continued doing mass media campaigns, more people could have screened, and people could have known the status of the TB.
Thank you very much. Now we've got a question to Dr. Rajaram. Thank you for your presentation. I saw that 71% was support by community health workers. What were the indications for support, and what are the characteristics of the 29% who did not receive any support? Dr. Rajaram? Dr. Rajaram, can you hear us?
There was some echo. I think your question was on how, why there was some echo. I think your question was on how, why there was some echo. I think your question was on how, why there was some echo. I think your question was on how, why there was some echo. I think your question was on how.
So, Dr. Rajaram, I think you need to switch off the.
Okay. I come out of that.
Yeah.
That thing. So your question was to why around 29% did not get support. Yes.
Yes, that's correct.
Yes. Okay. So that is mainly due to stigma and discrimination. Some of the people may not be interested for the follow-up by the CHW, even though we only identified these patients. That is why there are patients who are not followed up. Some of the patients, once they have started the treatment, they even shift their house to some other place. So this CHW will not be able to track that patient. That is why we could not follow up those around 29% or some patients, even though these patients were identified by CHWs. That is why we could not follow up them. Mainly stigma and discrimination, stigma may be there. That is why they are not interested for the follow-up by CHW.
Thank you very much. There is also a follow-up question. I believe it's also to you. Why 1% of the patients didn't receive any treatment? And can we have something to learn from the untreated 1%?
Okay, this is a very good question. But if you will see the government statistics, you can know that around 5 to 6% of the patients are not got treatment, even though they are identified as TB. One of the reason is that they might have shifted from this place and they might have gone for other tests also. But if you will compare with the government patients, it is only 6% were not taken treatment, but our this thing only 1%. Anyway, we can just see what is their characteristics if who are not went for treatment. Okay, that we can see. But compared to government supported these patients, government identified patients, there is 6% to 5 to 6% of the patients are not at all gone for the treatment. But in our case, CHW is identified and we are able to achieve 99% of the patients under treatment.
And one more follow-up question to that, Dr. Rajaram. What was the sustainability plan for the CHW program? Was it successful?
Actually, this is successful because we have already done system level field workers. We are given them training. Also, this community health workers will be working as a volunteers in the community. And similarly, we have generated so many knowledge among the CHWs, so that knowledge about TB will be remains in the community. So they will be working as a volunteer, even though they are not getting any salary or something, because they are from the community, they are from the slum areas, so they will be working for that community. Also, we have given counseling training to the government staff, and we have strengthened those government staff.
Thank you very much. We now got a question to Dr. Varsha and the PSI team. Congratulations on the e-pharmacy deployment. Do you see this as a scalable model moving forward as virtual TB care and consultations are being preferred in this COVID environment? Dr. Varsha?
So, on behalf of the I am replying to such a question.
Dr. Varsha, I think your connection is not very stable. Okay, I think we've lost the connection there, so we'll come back to our colleagues in India later. There is a question for the self-screening again, so I think that's you, Eunice, if Eunice is still online. Yes. So the first question to you, Eunice, previous presenter, how did you make sure that the policymakers accept the digital health app and how it is scaled up through the country?
Actually, firstly, we engaged all stakeholders so that they could start understanding about this application and accepting it from the beginning. The NTLP were the lead in developing and engaging the stakeholders, so they owned the intervention. It wasn't very hard for it to be accepted and to be put on the platform of the government. So the main thing we did is to engage the right individuals, the right stakeholders, so that this application could be accepted and be sustainable in the government platform.
Thank you very much. There is also a follow-on question to that. What is the main reason people access the self-screening, and what information what information is able to drive them for self-screening? So what motivates them?
Actually, we developed a lot of mass media campaigns. We developed camp cards, posters, which had instructions on how to do self-screening, and we had this very beautiful video or spot which prompted people to screen themselves for tuberculosis. The first thing we should know that Tanzania has the education gap on issues of tuberculosis. So with them being prompted by using these various social media tools, it made them make them more curious to understand how this application works. So they started dialing. That's why I mentioned in my presentation that there are some who are just dialing and screening themselves so that they could just know how the application works. They were not really, they didn't have even the signs of tuberculosis. Some of them were just curious. Some of them were just teaching others on how to do self-screening. So people used the application so that they could understand their health status on pertaining to TB and also get the TB knowledge. Apart from doing screening, there's also TB knowledge to the community.
Thank you very much. I believe Dr. Varsha is back online, so maybe we can revert to that question. Dr. Varsha and PSI team, congratulations on the e-pharmacy deployment. Do you see this as a scalable model moving forward as a virtual TB care and consultation as they are preferred in this COVID environment? Can you speak to that, please?
Yeah. The e-pharmacy model has started with the public sector, private sector, and over a period of time.
Yes, you hearing me?
Yes, we hear you now.
Prabhat
Please
will explain, ma'am. Yeah.
Yeah. So COVID-19 situation, what happened was that even apart from private sector, the drug delivery thing in the government sector had faced some hindrance, and so even both public and private sector patients got doorstep delivery through this e-pharmacy model in Madhya Pradesh, in the 3 districts that we are working in.
And I believe you said earlier as well that the government of India has actually added additional funding and is willing to scale up because of the COVID-19 situation. So rather than it being constrained, it actually has a benefit for you because the government is now willing to invest. Do I understand that correctly?
The government is, the thing is that between March to July, the COVID situation was rampant in Madhya Pradesh, and so the focus was more on controlling the COVID situation. And in that context, in certain public sector facilities, services were hindered. But overall, the government of India has a commitment to eradicate it by 2025, and the government of Madhya Pradesh under the mission director and all are geared up to eliminate this entire TB thing. Every year for a specific district, say 15 to 20% of the areas will get COVID free by each year. We have targets for that, and our STO madam, Dr. Varsha, is directly monitoring the situation at the district level, both for drug delivery, treatment, and everything that is taking place.
Okay, I think our line has dropped again. We've lost the
Pardon?
last sentence. Can you repeat the last sentence, please?
Yeah, the state TB officer, Dr. Varsha, is monitoring the situation whereby in state of Madhya Pradesh, we have a plan to eliminate TB for India, it is target of 2025. Madhya Pradesh has an ambitious target to do it by 2022. And so beginning this year, we have 25 of the districts which will be TB free, we believe. Obviously, the COVID situation has complicated matters, but still the state is hopeful that it will drive the specific its own policy, and we have a state specific guideline paper also on the same, whereby we have a specific districts where TB will be eliminated by say 2021, 20 and by 2022. And by 2025, we definitely think that at least this state will have TB eradicated goals of Government of India. And obviously,
Thank you very much. Just a practical question as a follow-on. The e-pharmacy project, were the patients actually diagnosed at home, or were they diagnosed by a visit to the health facility?
So if I get your question correctly, once a private provider diagnose a client, even from sputum testing at the government facility to providing drugs for 6 months, everything is done in a coordinated manner. The drugs are from the government supplies. It is the e-pharmacy player picks up from the government stores and delivers it to the doorstep of the patient.
But where are the patients diagnosed? Are they diagnosed in the health facility or at home?
The patients are
at health facility, ma'am.
At private health, focus is on private health facilities.
The e-pharmacy field staff, they transport the sample collection to the government lab for the CBNAT testing or the sputum examination.
Okay, thank you very much. We've got a question for Uganda, Pius. Can you elaborate on how you've scaled up your quality improvement model in the facilities? Pius, you need to...
Thank you very much. I don't know whether people can get me well. Yeah, this was done at one facility, Kapelebiong Health Center 4, but at my position as a district TB and leprosy supervisor, the district has more facilities offering TB and HIV services. We do routine mentorship, we do on-job coaching. Time and again, we do visit different facilities on monthly and quarterly basis. And this is the best opportunity when we cascade this information, this best practice to the rest of the health facilities. And then we also have regional convenings within our region. Some of these best and they are implemented in different districts, and therefore it keeps growing.
Pius, your sound has dropped.
To national level. Should I have to repeat that again?
Just the last sentence, please.
Yeah, I was saying that besides the monthly and quarterly mentorships that we provide at the district level, we also have regional meetings, regional convenings where we share a lot of challenges and also share our data at the region, which we have representatives right from the National TB and Leprosy Program, and some of these best practices this is the way it cascades to the rest of the other districts and the regions.
Just out of interest, my own follow-up on that one, as your quality assurance has quite a lot to do with actually face-to-face meetings in the districts, how did you deal with that during the COVID pandemic? Did you struggle to implement this? Did you find any creative ways about that?
On a honest note, COVID-19 pandemic, at the time it hit, of course, brought a definite challenge to implementation of this approach. But time and again, with engagement and replanning here and there, with a lot of sharings, we also had to remodel and observing the COVID guidelines at the same time. Well, when the COVID hit, we had a disorganization in our approach. We had to decentralize patients. We had to go into another mode of, say, delivering drugs into homes and so forth. But we are getting back online. We are getting back online, but observing the COVID-19 precautions. Yep.
Thank you very much. That's really interesting, because I do think that is the big question on everybody's mind at the moment. Is we had a very good program, but how do we do it now that everything has changed? I will probably come back to the other presenters in a minute on the same question, so prepare yourself. But another follow-up question for Dr. Varsha first. Was the contract with the private company for the delivery of TB drugs paid by the government, or was it paid by patients accessing the services? Also, do you think this service can also be offered to patients that are consulting in the public sector?
So as a pilot, this was supported by APT Associate under USAID funding. Over a period of time, the government is planning to fund the entire e-pharmacy model once this pilot phase ends. And the other is that obviously the government is willing to support the entire process. And there is a buy-in from the government at the highest level, from our mission director, National Health Mission, and even senior officials.
Thank you very much. Now there's one question left, and that's for Jennifer, but Jennifer isn't online today, so we will pass that on to her and make sure that she gets back to you. The problem is that the question is posted by Anonymous. So if you want to help us getting back to you on this one, could you please repost the question and let us know who you are and how we can reach back to you? Because the question is a really interesting one. So the question is, it seems that social issues really drive the adherence challenges. And do you think addressing this might be the main, I guess, way forward? But that might also be a good question to ask everybody else. So maybe in the final round of, if there's no more questions coming in of our presenters, if you could all speak just for a couple of minutes on how did COVID impact your program and any great ideas on how to solve this? It's probably the Nobel Prize question. And the second one is, how much do you see that social issues are affecting any of the success or of just your way forward, and any tips and tricks you can give your colleagues here? So maybe we start again with Pius.
We lost him.
Pius, are you still there?
I'm here. I was actually typing some answer on the question. Let me get you right. Let me get you again.
Yes. So basically the question is, you've already talked about how COVID impacts your situation, but if you can talk a little bit about social issues, how that drives your activities or hinders your activities, and what you're doing about that.
Well, at the beginning of this implementation of this good practice, there was a vast challenge, and the biggest challenge here was the knowledge the community, the people, the clients, the parents, the caretakers didn't have this information of how good IPT could benefit their children, how it could benefit the community and the rest. And one thing we have done and intensified on is information giving. In each and every client visit, we do targeted health education and engaging them to share their challenges in different, and also we have routine reviews of this kind of data to understand and the challenges and be able to plan and replan on the best way to approach different setbacks that we meet along the way. And the emphasis at the moment right now with the current COVID-19 is the integration of the IPT programming with the rest of the available structures, and the focus is still strengthening the community understanding the end.
Okay, I think you're dropping out at this point. Let's, I hope people have heard it better than I have. Dr. Rajaram, would you like to comment on this? So the questions are, how do social issues impact your activities, but also how does COVID impact your activities and any workarounds?
Okay, I will explain. First, we have started with the lockdown in India. We have started with the lockdown from 23rd or 24th of March, and it was gone up to around May. First week, it was very high. So during that period, there may be some problem, but afterwards, our field staff is still going. We have another project which is a private engagement. So our field staff is still going for the field work, and it was not affected. And some of the field workers also got COVID, and they are also actually got treatment, and some almost all the people who are got COVID also was cured. And this is having one of the main advantages was that most of the people started wearing mask. Whenever I will go some of the field visit, I have seen that TB patient in Hyderabad uses mask, but in Bangalore, these patients may not wear. So this is an opportunity that mask wearing is improved, and how that will impact the TB infection we have to see. And now what is happening is that TB notification has been reduced because the government facilities are giving more importance to COVID. That is my viewpoint on this. Okay.
Thank you very much. I think it's a really good point there. Eunice, would you like to comment as well, please? You're muted.
Thank you. In Tanzania, actually, we did not have a complete shutdown or lockdown, but some of the offices were locked and we were working from home. And what we did with the project we are implementing right now, it's a new project. So the activities which were going to be done between March to June were rescheduled. They are moved forward so that we were able to just do things which will need us to work on our laptops only, or use computers in communicating, but not traveling to the field or going to the health facilities for within that period of 3 months. So what Tanzania is doing right now, it wants to help the healthcare workers not to miss our patients, the patients with TB. They are in the process of developing a document which is going to guide the healthcare workers on how to identify TB patient from the corona, because the signs and symptoms are almost the same, which is a challenge, and somehow they end up being missed by being thought that they have corona. without really knowing the differences. So a document is being made right now, which is going like a terms of reference. It's going to guide all healthcare workers to know how to differentiate the two diseases and how to not miss our TB patients. Thank you.
Okay, thank you very much. Peter, would you like to comment as well? I'm putting you on the spot now. Peter, can you hear me?
Yeah, I can hear you, Kathy. Thank you very much, everyone, for the science and the showing us the best practices. And our presentation by our neighbor, Tanzania, where we heard that there wasn't any much complete lockdown. But here in Kenya, we're still having a higher incidences of COVID right now. And the government is not sure whether we should go back to shutdown or we should persevere for herd immunity. It's a political decision, and it's very difficult for us, but we somehow we are managing in Kenya. But of course, again, as like most of us have said, this has affected the TB programs in a number of cases, and we have a situation where we are going to go back to a few, or rather many steps back in TB prevention. Thank you, Kathy, and thank you, everyone.
Thank you very much. Dr. Varsha, would you like to add anything? You've typed earlier here for me to say that the initial period was quite challenging in your program. Do you want to add anything to this?
Yeah, so this entire COVID situation has had some positive effects also, like wearing of mask and maintaining a distance has helped in decreasing the TB clients' active cases. So these are the positive effects. However, there are many negative effects, like people don't go for testing just thinking that they might be tested positive for COVID. So the stigma attached with COVID-19 is definitely affecting the overall program. But now that at this point of time, there has been unlocking and all, so the entire drug supply, active case finding is now being done in a proactive manner, and people are getting less apprehensive. Still, the program has some challenges with COVID-19 situation.
And especially, ma'am, more than 75% field staff, they are involved in COVID duty.
Yes. Yes. Well, thank you very much. I mean, this session has given me an awful lot of food for thought. I think we are in this dual pandemic together, but I think it is really very encouraging to hear your presentations today, everyone, because I do think there's lots of things in there that can help us, especially in this time. Having ways to bring drugs to patients at home, having ways to help people screen at home, having ways of supporting the healthcare workers to provide quality care in a fashion that will really provide the best care that we can in the very difficult circumstances, knowing how we can use digital technology. So again, I would like to encourage everyone to keep the discussion going, keep telling each other on what works, not just to dwell on the difficulties. I think we all have difficulties, but it's good to discuss those, but then to really look forward and see how we can help each other and learn from each other. And I'm really very grateful that we have had the chance to talk about that today in this session. So thank you very much, everyone. And if there is no other questions, then we can declare this session closed. Thank you very much to all the presenters for a fabulous presentation.
Thank you.
Thank you, everyone, and have a lovely evening.
Thank you.
Bye-bye, everyone.
Bye-bye.